This conference will now be recorded.
Today's topic is ocular manifestations of diabetes. The term diabetes mellitus describes the metabolic disorder of multiple etiology characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism resulting from defect in insulin secretion, defect in insulin action, or both. Both there is defect in insulin secretion and insulin action. The effect of diabetes mellitus includes long-term damage, dysfunction, and failure of various organs. It mainly microangiopathy, that means it affects the small vessels, causes diabetic retinopathy, nephropathy, neuropathy, and heart diseases. These are the most commonly affected organs in diabetes. Eyes most commonly retinopathy, kidneys nephropathy, and neuropathy, peripheral neuropathy, and heart diseases, coronary vascular diseases, ischemic heart attack. Ischemic heart attack is most commonly caused by diabetes. High blood glucose levels cause endothelial cell lining blood vessels to take in more glucose than normal. These cells do not depend on insulin. They then form more glycoproteins on the surface than the normal. Also cause thickening of the basement membrane. There will be thickening of the basement membrane. The wall of the vessels becomes abnormal thick but weak, and they will bleed. There will be loss of intramural pericytes. The most important aspect of diabetic is it is microangiopathy. It is affecting the small vessels, and there is loss of pericytes of the small vessels. So they leak. Whenever there is loss of pericytes, so they bleed, they leak the protein and slow the flow of blood through the body. That is the main pathology. Loss of intramural pericytes, abnormal thickening of the basement membrane. So there is, because of the loss of intramural pericytes, there will be bleeding, leaking of the proteins, and slow the flow of blood through the body. This is the picture where you can see there is loss of intramural pericytes. There are loss of pericytes are lost. So whenever there is loss of pericytes, there will be leakage from the small vessels. There will be thickening of the basement membrane, endothelial cell damage. Basement membrane is thickened. You can see here the basement membrane is thickened. Damage to the endothelial cells, change in the shape of the RBC, increased thickness of the platelets. This is the pathology of diabetes. Any retinopathy or neuropathy or nephropathy, mainly retinopathy. In retinopathy, there is loss of intramural pericytes, increased thickening of the basement membrane, change in the shape of the RBC, increased thickness of the platelets. All this condition leads to occlusion of the vessels and increased leakage from the vessels. Due to loss of intramural pericytes, there will be increased leakage. Due to thickening of the basement membrane, change in the shape of the RBC, increased thickness of the platelets, there will be occlusion of the blood vessels. So due to loss of pericyte, there will be also retinal edema, leakage of fluid from the small vessels leads to retinal edema and heart exudates. These are the heart exudates. And there will be formation of arteriovenous shunts. Due to occlusion, there will be formation of shunts and formation of vasoactive substance, VEGFs, vascular endothelial growth factors, resulting in rhabdosis iridis. That means new vessels on the, usually there will not be any vessels on the surface of the iris. There will be formation of new vessels on the surface of the iris, and also proliferative diabetic retinopathy. Proliferative retinopathy means neovascularization of the disc and neovascularization elsewhere. There are pathogenesis. One is loss of intramural pericytes. The second one is thickening of the basement membrane, change in the shape of the RBC, increased thickness of the platelets, resulting in occlusion. Loss of intramural pericytes resulting in leakage from the vessels, leading to retinal edema and heart exudate. And Whenever there is occlusion, there will be formation of shunts, arterial venous shunts, which leads to production of vascular endothelial growth factors. These vascular endothelial growth factors leads to proliferation of abnormal blood vessels on the surface of the iris and retina and on the disc. There is proliferative diabetic retinopathy, neovascularization of the disc and neovascularization of the elsewhere. NVD and NVE, you know that. Non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative is divided into mild, moderate, severe, and very severe. Proliferative is divided into NVD and NVE. That is the classification of diabetic retinopathy. Non-proliferative and proliferative. Non-proliferative is again divided into mild, moderate, severe, and very severe. PDR is neovascularization of the disc and neovascularization elsewhere. There is the classification of ETDRS classification of diabetic retinopathy. Extended treatment diabetic retinopathy study. Diabetes can cause changes to virtually all the structures of the eye. Cornea, there will be changes in the cornea, reduction in the tear production, there will be changes in the aqueous, composition of the aqueous, changes in the iris. Already I said there will be neovascularization of the iris, producing neovascular glaucoma. Lens, there will be formation of diabetic cataract due to increase in the refractive. The lens imbibes more fluid and there will be increase in the refractive index of the lens and myopic shift and vitreous. Retina, you know, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Extraocular muscles, there will be paralysis of the extraocular muscles leading to squint, diplopia and squint. Lids and conjunctiva, they are more prone to infections due to high blood sugar level, recurrent styes and blepharoconjunctivitis, loss of tears and genital asthma. These are the effects on the lids and conjunctiva. You can see here, small sty is there here, podulum externum or small sty. Cornea. Cornea sensitivity is commonly impaired in diabetes. The sensory deficit may predispose to bacterial corneal ulcers, neurotrophic corneal ulcers, and in particularly with difficulties with contact lenses. They will have the patients with contact lenses that are prone to more infections. There will be sensory deficit may predispose to bacterial corneal ulcers and neurotrophic corneal ulcers. This is a picture showing bacterial corneal ulcer. Intrinsic abnormalities of the epithelial basement membrane complexes with impaired barrier function leads to superficial punctate keratitis and poor healing after trauma. There will be poor healing after trauma. Thickening of the basement membrane leads to the superficial punctate keratitis and poor healing after trauma. Rigid pupils, there will be difficulty in mydriasis. You can see when you apply a tropicamide and phenylephrine drops, there will not be much dilatation. That is called rigid pupils. The cause is autonomic neuropathy, partially denervating both sphincter pupillae and dilator pupillae. Due to autonomic neuropathy, there will be denervation of the nerve supply to the sphincter pupillae and dilator pupillae, due to which there will be only partial dilatation or no dilatation. Particularly during cataract surgery, there will not be any dilatation. Eye drops of the iris. Rubeous iris, you can see here. Neovascularization of the iris. You can see the abnormal blood vessels on the surface of the iris and pupillary margin. Here also you can see the abnormal blood vessels on the surface of the iris. That is called rubeous iris. In later stages, it leads to neovascular glaucoma. Neovascularization of the iris. Retinal hypoxia. Retinal hypoxia releases vascular endothelial growth factors, which induces new vessels formation on the surface of the iris and pupillary margin. Later, it leads to neovascular glaucoma. These new vessels, they leads to pulling of the peripheral iris, peripheral anterior synechial formation and closure of the angle. That is called Jipper angle closure. So it leads to formation of neovascular glaucoma. That is called Jipper angle closure. Glaucoma, it is a complication of reverse iris. I already told you it leads to reverse iris leads to Jipper angle closure formation, leads to rise in intraocular pressure and neovascular glaucoma. Lens, there will be change in the refractive error. Collection of the sugar alcohol sorbitol in the lens due to increased aldose reactive activity causes the lens to swell and change in its refractive power. There will be increased fluid retention inside the lens and leads to change in the refractive power. There will be myopic shift. Increase in blood sugar level due to hyperglycemia causes increase in the osmotic pressure of the crystalline lens. So it absorbs more fluid into the crystalline lens. So there is increase in the refractive index of the lens leads to myopic shift. Hypermetropic shift, there will be decrease in the blood sugar level during hypoglycemia. There is a decrease in the osmotic pressure of the crystalline lens and decrease in the refractive index of the lens. That leads to hypermetropic shift. Decrease in the blood sugar level due to hypoglycemia leads to decrease in the osmotic pressure of the crystalline lens, leading to decrease in the refractive index of the lens, leading to hypermetropia. You know, hypermetropic what means? The parallel of the eyes, they are focused beyond the retina. Whereas myopia means they are focused in front of the retina. The parallel rays of eyes coming from the infinity are focused in front of the retina is called myopia. You can see they are focused in front of the retina. Here it is the retina. Here they are focused beyond the retina. That is called hypermetropia. Cataract is a major cause of vision impairment in people with diabetes mellitus. It occurs 10 to 20 years after the onset of insulin-dependent diabetes. Control of diabetes with restoration of normal blood glucose levels stops the progression of opacity. True diabetic cataract. This is a picture showing true diabetic cataract, also known as slow-fake cataract or snowstorm cataract. This is a pre-senile cataract. This is the difference between true diabetic cataract and senile cataract. This is a true diabetic cataract, also called snowflake cataract or snowstorm cataract. Diabetic neuropathy, there will be paralysis of extraocular muscles innervated by the third and sixth nerve. Most commonly, sixth nerve is frequently involved, third and sixth nerves are frequently involved. If there is paralysis of third and sixth nerve, there will be diplopia, sudden onset of diplopia and painful muscle paralysis associated with ipsilateral headache. Short duration of hyperglycemia in diabetes, the paralysis disappears spontaneously within several weeks. If the hyperglycemia is of short duration, the paralysis disappears spontaneously. But in cases with long-term hyperglycemia and diabetes, the paralysis of the extraocular muscles will persist up to 6 months. So you have to control the blood sugar levels. Once the blood sugar is controlled, the paralysis regains. It will remain normal activity. The muscles regain normal activity, and diplopia, all these things will disappear. So you have to control the blood sugar level. Whenever there is a patient with diabetes comes with paralysis of the extraocular muscles, diplopia, severe headache, so you have to ask the patient to control the blood sugar levels. Once the blood sugar is controlled, it resolves spontaneously within several weeks. If the diabetes is of long-term hyperglycemia, the muscle paralysis may persist up to 6 months. If you tell the patient, you have to wait for 6 months and give some multivitamin tablets. Medical lesions in diabetes usually spare the pupil comparing with the surgical lesions. Compared with aneurysm, which involve the pupil. Aneurysms usually involve the pupil, whereas medical lesions will not involve the pupil. This is a surgical lesion. If the lesion is surgical compressing the blood vessels, it leads to involvement of the pupil. There is a medical lesion, it does not involve the pupil. Because the microangiopathy, which involves the vasa nervorum, causing ischemia of the main trunk of the nerve and sparing the superficial pupillary fibers. Superficial fibers are spared, only the central fibers are involved. Microangiopathy, because of microangiopathy, the central fibers are involved, sparing the superficial fibers. While spare the pile vessels which supply the superficial pupillomotor parasympathetic fibers. Because the blood vessels are not involved in medical lesions. The superficial blood vessels are not involved in medical lesions, whereas in aneurysms, they cause compression of superficial blood vessels and causes involvement of the sphincter pupillae and dilator pupillae. That is, the pupils are more commonly involved in surgical lesions like aneurysms and tumors. Because of the superficial pile vessels are involved. They supply the parasympathetic fibers of the pupil. These spiral vessels, they supply the parasympathetic fibers. When medical lesions are present, these spiral vessels are not involved. So pupils are not affected. But in tumors and aneurysms, these spiral vessels are involved, which supply the pupil, parasympathetic pupillomotor fibers are involved, leading to paralysis of the sphincter pupillae and diameter pupillae. Retinopathy is the most important complication of diabetes. Prevalence of diabetes retinopathy of any severity in the diabetic population is 30%, and prevalence of blindness due to diabetic retinopathy is approximately 5%. Prevalence of diabetes retinopathy in diabetic population is 30%. Among the diabetes, the prevalence of diabetic retinopathy is 30%, and loss of blindness and prevalence of blindness in diabetic retinopathy is 5%. Control of diabetes mellitus will not prevent but delays. Hypertension. Risk factors for diabetes mellitus includes diabetic retinopathy includes hypertension, renal diseases, pregnancy, obesity, hyperlipidemias, smoking, and anemias. I always told you there is lots of intramural pericytes and thickening of the basement membrane, proliferative and damage of the endothelial cells, increased capillary permeability due to loss of intramural pericytes, and abnormal vasoproliferation. That means ischemic retina will produce vascular endothelial growth factors which leads to neovascularization. This is the pathology: loss of intramural pericytes, thickening of the basement membrane. So due to loss of intramural pericytes and thickening of the basement membrane, I have already told the pathogenesis. There will be change in the shape of the RBC, increased stickiness of the platelets, thickening of the, all these factors leads to obstruction of the vessels leading to ischemia. Loss of intramural pericytes leads to increased vascular permeability leading to leakage of the fluid, proteins, and leading to heart exudation and retinal bleeding. This is a normal picture. Here you can see there is a loss of intramural pericytes leading to formation of microaneurysm. This is a microaneurysm here. This is a normal blood vessels. This is a picture showing loss of intramural pericytes leading to microaneurysm. This is the formation of microaneurysm. Classification of diabetic retinopathy: non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative is again classified into mild, moderate, severe, and very severe. Proliferative is severe into mild to moderate, severe, and advanced diabetic retinopathy. Mild means presence of at least one microaneurysm. This is a microaneurysm. At least one microaneurysm. Review in 1 to 2 years. You have to review every 1 to 2 years. If the patient has mild retinopathy, you should ask the patient to come after 1 year again. That is called mild. If at least one microaneurysm is present, is called mild diabetic retinopathy. Moderate includes signs of hemorrhages, microaneurysms, and heart exudates and cardinal spots. This is a microaneurysm. This is the hemorrhage. These are the heart exudates. This is a cardinal spot. Microaneurysm. This is a hemorrhage, heart exudates, and cardinal spot. If all these are present, it is called moderate diabetic retinopathy. You have to review this patient every 6 months to 1 year. The patient has moderate diabetic retinopathy. Severe means hemorrhages and microaneurysms in all the 4 quadrants. Venous bleeding. This is the venous bleeding. Venous bleeding in 2 quadrants. IRMA, centroretinal microvascular abnormalities in 1 quadrant. If any one of the 4:2:1 rule is present, if any one of these signs is present, it is called severe diabetic retinopathy. Hemorrhages and microaneurysms in all the 4 quadrants, venous bleeding in 2 quadrants, IRMAs in 1 quadrant. If any one of the 4:2:1 rule is present, it is called severe diabetic retinopathy. Very severe means if any 2 of the above is present, it is called very severe diabetic retinopathy. Microaneurysms and hemorrhages in all the 4 quadrants, venous bleeding in 2 quadrants, IRMAs in 1 quadrant. If any 2 of these is present, it is called very severe diabetic retinopathy. Neovascularization elsewhere, proliferative diabetic with retinopathy, neovascularization elsewhere, neovascularization of the disc, vitreous hemorrhage and period. Whenever there is a neovascularization, it causes bleeding. Abnormal vessels, what they will do, they bleed. So it leads to vitreous hemorrhage and periretinal hemorrhage. This is neovascularization elsewhere. New vessel formation on the surface of the retina. This is the neovascular. You can see the new vessels on the disc, neovascularization of the disc. All these are the new vessels on the disc. Visual loss in diabetes is caused by maculopathy, vitreous hemorrhage, and retinal detachment. This is the how the picture appears in patient with diabetic retinopathy. This is a normal vision. This is how the same picture appears for a patient with diabetic retinopathy. Main cause of visual loss in diabetic retinopathy: edema, ischemia, and exudate formation. Whenever there is loss of intramural pericytes, there will be microaneurysm formation. There will be secretion of the fluid, hard exudates, all cotton spots, microaneurysms, leads to swollen retina. This leads to swollen retina. Loss of intramural pericytes, thickening of the basement membrane. All these things, they leads to secretion of the fluids and swollen retina. This is a picture showing hard exudates. These are the hard exudates. This is a cotton wool spot. This is a normal retina, and this is a diabetic maculopathy, where you can see hyperfluorescent, multiple hyperfluorescent areas in the macular area. These are the ischemic areas. Capillary dropout is called ischemic area. This black one is called ischemic retina because there is capillary dropout in this region. It leads to ischemic retina. This is multiple hyperfluorescent spots. These are microaneurysms leading to hyperfluorescence. These microaneurysms are giving hyperfluorescence. This is the fluid. This wide white area is called fluid. The small dot-like hyperfluorescent areas are due to microaneurysm. These are due to microaneurysm. This is a picture showing macular edema. Here you can see the edema. These are the cysts. This is a picture showing macular edema in OCT. This is a vitreous hemorrhage, boat-shaped subhyaloid hemorrhage. This is a periretinal hemorrhage. This is a subhyaloid hemorrhage, boat-shaped subhyaloid hemorrhage. This is a periretinal hemorrhage. This is a picture showing tractional retinal detachment. Which type of detachment occurs in diabetic retinopathy? Due to presence of fibrovascular glands, there will be tractional retinal detachment. This is also a picture showing tractional retinal detachment. Management, medical treatment, observation, laser therapy, anti-VEGFs, and vitrectomy. Laser therapy reduces the severity of the visual loss, reduces legal blindness by 90% in people with severe NPDR. Indications: PRP is advised in proliferative diabetic retinopathy. Diabetic macular edema, you have to give focal laser or grid laser. C-shaped focal laser is indicated in diabetic macular edema. Pan-retinal photocoagulation is indicated in patients with proliferative diabetic retinopathy. This is the picture showing pan-retinal photocoagulation. You have to give the laser burns. 3000 to 2500 to 3000 laser burns are given in the entire retina. These are the laser burns. These are all the laser burns. So it causes shrinkage of the abnormal vessels. Laser burns causes shrinkage of the abnormal vessels. Sometimes you have to give simultaneously both laser and intravitreal injections, anti-VEGFs. They are called antivascular endothelial growth factors. This is a picture showing neovascularization of the retina, NVD and NVE. This is a picture following pan-retinal photocoagulation. You are given the 2500 to 3000 laser burns in the entire posterior pole. There will be shrinkage of the blood vessels or regression of the blood vessels, abnormal blood vessels. Here you can see these are all the abnormal blood vessels. All these blood vessels are disappeared once following pan-retinal photocoagulation is given. Focal laser, in cases with clinically significant macular edema, you should give a focal laser here. C-shaped, in a C shape, grid laser or focal laser, it causes resolution of the CSM, clinically significant macular edema. Here you can see before laser, this is the picture showing after laser. All the odd dates and edema has disappeared. Anti-VEGFs, bevacizumab, the trade name is Avastin, ranibizumab, trade name is Lucentis, aflibercept, the trade name is Eylea. Avastin or bevacizumab, this is the most commonly used anti-VEGF drug. It is a part of class of drugs that blocks the growth of abnormal blood vessels. Was initially approved by FDA as a treatment for colonic cancer. It was initially approved by FDA for treatment of colonic cancer. It is used off-label to treat the eye diseases such as diabetic retinopathy, retinal vascular occlusions, wet AMD, wet age-related macular degeneration. This drug can stop the blood vessels leaking and growing. Benefits of Avastin in diabetic retinopathy includes it prevents proliferation of proliferative diabetic retinopathy and diabetic macular edema. It could also complement the focal photocoagulation in diabetic macular edema and as an adjuvant agent in pan-retinal photocoagulation and proliferative diabetic. I have already told you it can also be used as an adjuvant treatment for pan-retinal photocoagulation, PRP, in proliferative diabetic retinopathy. Both pan-retinal photocoagulation and intravitreal bevacizumab, Avastin, can be given for treatment of proliferative diabetic retinopathy. Vitrectomy, this is indicated in patients with fractional retinal detachment. It consists of fiber optic probe and a vitrector and an infusion line. This is the infusion line. This is a fiber optic probe for illumination, and this is a cutting tip. So it removes the blood vessels, removes the tractional bands, and it also allows the PRP. Once you remove the blood and the tractional bands, you can do pan-retinal photocoagulation. There will be poor visibility due to presence of blood and tractional bands. Once you remove the blood and tractional bands, you can do PRP, pan-retinal photocoagulation. This is a picture with vitreous hemorrhage. So you have to do vitrectomy. Once you do vitrectomy, you remove the blood and tractional bands. So this is a picture after vitrectomy. So you cannot see any blood vessels or disc or anything due to vitreous hemorrhage. Once you remove the blood, tractional bands with vitrectomy cutter, this is how the retina appears, and there will be significant improvement in the vision also. Vision outcome also will be much better. This is the difference between diabetic retinopathy and hypertensive retinopathy. Diabetic retinopathy, there will be dot plot hemorrhages, whereas in hypertensive retinopathy, you see flame-shaped hemorrhages. You see more commonly hard exudates in diabetic retinopathy. Cotton spots are more commonly seen in hypertensive retinopathy. Hard exudates are more commonly seen in diabetic retinopathy, whereas cotton spots are more commonly seen in hypertensive retinopathy. Neovascularization of the disc and neovascularization elsewhere is seen in, this is neovascularization. You see in diabetic retinopathy, whereas papillary edema is seen in hypertensive retinopathy. Grade 4 hypertensive retinopathy, there will be papillary edema of the disc. Once the hypertension is controlled, the edema resolves. These are the various treatments: pan-retinal photocoagulation, focal laser or grid laser, intravitreal anti-VEGF drugs. These are all the treatments for diabetic retinopathy. Whereas for vitreous hemorrhage and tractional retinal detachment, you have to go for vitrectomy. This is a picture before PRP and after PRP. Here you can see the neovascularization of the entire retina and disc. And after PRP, there is regression of the vessels on the retina. These are the laser burns. Pan-retinal photocoagulation. You apply the 2000 to 500 to 3000 laser burns throughout the retina. It leads to regression of the vessels. You can combine along with PRP. You can give intravitreal anti-VEGFs, that is Avastin, that is bevacizumab, ranibizumab, and bevacizumab is Avastin, ranibizumab is Lucentis. Retinal finding normal. Sustained follow-up is annually. Mild NPDR, you have to the follow-up after 1 year. Moderate NPDR, follow-up is every 6 months to 1 year. Severe NPDR, the follow-up is every 4 months. Diabetic macular edema, the follow-up is every 2 to 4 months. Proliferative diabetic retinopathy, the follow-up is every 2 to 3 months. This is a picture showing tractional retinal detachment in diabetic retinopathy. These are all the fibrovascular bands. They pull the fibrovascular bands, they pull the retina away from the sensory retina, away from the retinal pigment epithelium, leads to tractional retinal detachment. Which type of detachment occurs in diabetic retinopathy? Tractional retinal detachment. Where do you see exudative detachment? In inflammatory conditions of the retina and uvea, you see exudative detachment. That is Coats disease, uveitis, all these conditions causes exudative detachment. Whenever there is a trauma, it leads to rheumatogenic detachment. These are the three types of detachment of the retina: rheumatogenic detachment, exudative detachment, and tractional detachment. Tractional detachment usually occurs in neovascularization. The fibrovascular bands will pull the sensory retina away from the underlying retinal pigment epithelium, causing tractional retinal detachment. Whereas inflammatory diseases like Coats diseases, due to under inflammation, there will be secretion of the fluid between the sensory retina and retinal pigment epithelium. So it will elevate the overlying sensory retina, leading to exudative detachment. It will appear, if exudative detachment appears as bullous detachment. Rheumatogenic means there will be a pre-existing break, so the liquid vitreous gel will seep through the pre-existing break and lifts the retina. That is called rheumatogenic detachment. There are the three types of detachment: rheumatogenic detachment, exudative detachment, and tractional retinal detachment. This is a picture showing subhighlighted boat-shaped hemorrhage. This is also vitreous, both are vitreous hemorrhage. This is a subhighlighted boat-shaped hemorrhage. The treatment of vitreous hemorrhage is vitrectomy. The picture showing diabetic macular edema in OCT, ocular coherence tomogram. This is a picture of diabetic maculopathy. This is a normal picture and maculopathy picture where you can see hard exudates. These are all the hard exudates, microorganisms, dot blot hemorrhages, and cotton spots. These are microorganisms and FFA, fundus fluorescent angiogram, where you can see the hyperfluorescent dots. These hyperfluorescent dots are microorganisms. This is the fluid. The remaining hyperfluorescent area is the macular edema. This is a ischemic area, capillary dropout area. Because of capillary dropout, there will be ischemic area, and it appears as hypofluorescent. Where you can see here, it is normal appearing, it is hypofluorescent appearing. Because there is no capillaries, the same area becomes ischemic and appears as hypofluorescent. Because there are no capillaries, it appears as hypofluorescent. This is a picture with the normal vision, whereas this is a picture with the diabetic retinopathy vision. The patient with diabetic retinopathy, how the picture appears. This is neovascularization elsewhere. This is neovascularization of the disc, NVD. NVE and PDR is classified into, proliferative diabetic retinopathy is classified into NVD and NVE. Non-proliferative diabetic retinopathy is classified into mild, moderate, severe, and very severe. According to ETDRS classification, the diabetic retinopathy is classified into mild, moderate, non-proliferative, and proliferative. Non-proliferative is again divided into mild, moderate, severe, and very severe. Mild means if at least one microorganism is present, it is called mild. Moderate means microorganisms, presence of hemorrhages, hard exudates, and cotton spots. If all these are present, it is called moderate diabetic retinopathy. Severe means 4:2:1 rule. Microorganisms in all the 4 quadrants, in venous bleeding in 2 quadrants, IRMA, intraretinal microvascular abnormalities in one quadrant. If any one of the 4:2:1 rule is present, it is called severe diabetic retinopathy. If any two of the above is present, it is called very severe diabetic retinopathy. This is the classification of diabetic retinopathy. Most important picture is medical lesions in diabetes mellitus usually spare the people compared with surgical lesions like aneurysms and tumors which involve the people, because the surgical lesions will compress the pile vessels which supply the sphincter pupillae and dilator pupillomotor fibers. The pile vessels which supply the superficial pupillomotor parasympathetic fibers. These pile vessels supply the pupil. Whenever there is macroaneurysm or tumors, they compress the pile vessels, leading to involvement of the pupil. Whereas medical lesions, they does not involve the pupil because it mainly involves the main trunk. The main trunk is involved in medical lesion. That is why it does not involve the pupil. This is a snowflake cataract, diabetic cataract. This is hypermetropic shift. This is myopic shift due to hyperglycemia. This is neovascularization of the iris. This is pure dilatation of the pupil because both sphincter pupillae and dilator pupillae are involved due to denervation of the fibers, autonomic neuropathy, partially denervating both sphincter pupillae and dilator muscles. This is a picture showing bacterial corneal ulcer due to abnormal cornea. This is podiolam externum, stye, small stye. This is the pathology where you can see there is loss of intramural pericytes. Due to loss of intramural pericytes, there is leakage of the vessels, there is leakage of blood fluid, fat, everything, leading to hot exudates and edema. Thickening of the basement membrane, change in the shape of the RBC, increase the stickiness of the platelets, it leads to occlusion. Once there is occlusion, it leads to arteriovenous shunts, and production of vascular endothelial growth factors leads to reverse iris, neovascularization of the iris and neovascularization elsewhere, neovascularization of the disc. This is predominantly microangiopathy. You should remember this word. Diabetic retinopathy or nephropathy is predominantly it is a microangiopathy resulting in loss of intramural pericytes. Small blood vessels are involved. That is why it is called microangiopathy. All these pictures are very important for you. They will be made available in the website. If you want, you can download them. This is a picture, severe NPDR, very severe NPDR. If 4:2:1, if any of the two of the 4:2:1 is present, it is called very severe NPDR. There is a picture of neovascularization elsewhere. This is a picture showing neovascularization of this. These are all the abnormal blood vessels on the disc. Here you can see. These are normal vessels. This is the vein. This is the artery. This is the artery. This is the vein. This is the vein. This is the artery. But these small vessels which appear light in color, they are abnormal vessels. They are new vessels. They are appearing in the form of a fronds. They are abnormal. Here also you can see these are all the abnormal vessels here. Neovascularization elsewhere. This is neovascularization of the disc. You have to do pan-retinal photocoagulation and intravitreal injections of anti-VEGFs, Avastin and Lucentis. This is a picture showing diabetic macular edema. This one showing boat-shaped or subhyaloidal hemorrhage. This is a periretinal hemorrhage. This is a picture showing tractional retinal detachment. For tractional retinal detachment, you have to do vitrectomy. This is a picture of pan-retinal photocoagulation. where you have to give about 3000 burns to the entire posterior retina. This is a picture before PRP and after PRP. You can see the regression of the vessels. This is a picture of diabetic macular edema, only macular edema. So you have to give focal laser or grid laser. You can see the regression of the edema following focal laser or grid laser. These are the intravitreal drugs. Bevacizumab, the trade name is Avastin. Ranibizumab, the trade name is Lucentis. Aflibercept, the trade name is Eylea. Actually, Avastin is used for colonic cancer. It is used off-label for eye diseases, for diabetic retinopathy, retinal vascular occlusions, and wet AMD. The picture of showing vitrectomy, where you can see the endo-illuminator, vitrector, and this is the infusion cannula to maintain the intraocular pressure. The function of the vitrectomy is remove the blood, remove any tractional bands, and allow the PRP to function. The picture before vitrectomy and following vitrectomy, you can see how the retina appears clearly, and there will be improvement in vision also, significant improvement in vision also before vitrectomy and after vitrectomy. So this is ocular complications of diabetes. Thank you. Nice pictures. All these pictures are very excellent pictures. Predominantly, you should remember the word microangiopathy. Microangiopathy is a most important feature of diabetic retinopathy and nephropathy. Small vessels are involved. Okay, thank you.